Hello, my name is Charlotte and I'm a hepatobiliary dietitian working at the University Hospital of Wales, and today I would like to share with you my quality improvement project to improve post-operative nutrition in patients undergoing elective liver resection. This project was identified when I started in post. The current ERAS booklet for hepatobiliary resections was due to be updated in 2018 by the clinical nurse specialist. The ERAS book at the time required all patients to be given preoperative carbohydrate loading drinks prior to surgery, and a review of practice identified this was not being done. The evidence base of preoperative drinks in this patient group was questioned by the hepatobiliary team, as although there is strong evidence for colorectal and gastric surgeries, there appeared to be a minimal research into hepatobiliary surgery. The aim of the project was to improve the clinical outcomes of patients undergoing hepatobiliary resections using ERAS by October 2018. The ERAS pathway is an evidence-based and person-centred approach. It aims to improve surgical outcomes, put patients in an optimal condition for their surgery, ensure the best management during and after their surgery, and promote early rehabilitation to allow patients to return home and back to their normal activities quicker. This table shows the nutrition-related extracts from the ERAS recommendations for hepatobiliary surgeries. Point 4 refers to preoperative carbohydrate loading, which is currently recommended with an evidence level of low and a grade of recommendation of weak. Carbohydrate loading is strongly recommended in colorectal patients and may be recommended in liver surgery, as some data supports the deleterious effects of insulin resistance on liver regeneration. Preoperative carbohydrate loading involves taking carbohydrate-rich drinks prior to surgery and has been shown to reduce preoperative anxiety, hunger and thirst, reduce insulin resistance, reduce post-operative protein losses by promoting an anabolic state and preventing fluid and electrolyte abnormalities. In order to gain further knowledge of the effects of carbohydrate loading, I collected outcome data for 12 patients who were prepared for surgery as normal and 12 patients who received the carbohydrate loading drinks. The outcomes collected were length of stay, mortality, self-reported preoperative hunger, thirst and anxiety levels using scales, and maintenance of lean muscle mass using weights and hand grip strengths at day 2 and 3 and day 7. The results showed a 0% mortality rate in both groups. At day 2 to 3, there was a greater median weight gain for the patients who received carbohydrate loading, suggesting more post-operative edema. However, this could be skewed as 4 patients were unable to be weighed at day 2 to 3 in the patients who did not receive carbohydrate loading, versus 1 patient who did, suggesting poorer post-operative mobility. These 4 patients also had a longer length of stay. At day 7, there was less fluid gain in the patients who received carbohydrate loading. At day 2 to 3, patients who received preoperative carbohydrate loading had less loss of lean muscle mass as suggested by hand grip strength. At day 7, there was a higher median loss in the hand grip strength in the patients who received carbohydrate loading. However, at day 7, there was only 2 patients left in this group versus 6 in the group who did not receive carbohydrate loading. Of the 2 patients left, 1 patient had a large drop in grip strength of 41.8%. A drop of this level in a number of days should be attributed to fatigue, whereas the other patient had a reduction of just 0.82%. There was a reduced length of stay in patients who received carbohydrate loading. There was a reduced level of hunger and thirst in patients who received carbohydrate loading, and patients who received carbohydrate loading had an increased self-reported level of anxiety. Following on from the project, the next step was to feed back the results to the hepatobiliary team. Based on an estimated daily bed cost of £701.35 and 110 to 120 elective liver resections per year, the potential cost saving of reducing length of stay by 1 day is £77,149 to £84,162 per year versus £626 and 86 pence to £683.85 cost for the preoperative drinks. I also looked at what other sites were doing, and they were all also using carbohydrate loading as part of their ERAS pathways. It was agreed by the team that we should implement routine use of carbohydrate loading as part of our ERAS pathway, and the Plan Do Study Act method was used to do this. Here is an example of a Plan Do Study Act model, or PDSA cycle. In order to implement the prescribing of pre-op drinks, my plan was to educate the junior doctors and produce a poster to explain how to prescribe these. This was then implemented. I then collected data over 4 weeks and produced a run chart which showed 100% of patients were prescribed the drinks. My action at this point was to revisit in 1 year. This was the poster that was used to give guidance to the junior doctors on how to prescribe the preoperative carbohydrate loading drinks. It explains the benefits of carbohydrate loading to enable counselling of the patients. These were also available to the ward to hand out to patients when they were admitted to hospital. One year on from the initial project, I recollected data on the prescription of the preoperative drinks. There was a reduction initially of prescription rates to 66%. I suspected this was due to new junior doctors rotating into the team, so I completed another PDSA cycle and provided more education. Initially this was effective, however soon the percentage decreased again, highlighting the need for another PDSA cycle. At this point, the hepatobiliary surgery ward had moved and the poster was no longer on display. This was displayed again and prescription rates increased back to 100%. In conclusion, preoperative carbohydrate loading may be beneficial at improving outcomes after hepatobiliary surgery using ERAS. However, there is limited evidence in this patient group and research should be conducted. PDSA cycles are an easy and effective method of implementing change. Regular audit is recommended when change has been implemented due to the changeable nature of healthcare. In the next annual review, we will be collecting patient feedback to assess compliance and experience.